do in the summary of this mechanical ventilation 2, and then we go to the slide. I think all you are tired of listening lectures. We'll go to the slides because that was formulated very organized manner to cover things. So what the mechanical ventilation part 1 tells you, so far you learn what are the parameters of mechanical ventilation and how we usually use for common mechanical ventilation scenarios. Now, the mechanical ventilation 2 basically describe the uncommon situations or difficult ventilation situation, basically. That's, you have modules is with you, I think. You have that on the slides and the module. So that's basically, it's explained the mechanical ventilation 2 is actually for difficult cases how you ventilate and how the parameters change. When you are changing the parameters, what will happen? So for that, you should understand some physiological background for this. Actually, if we have the pointer, that's fine, but anyway. The first case is difficult to ventilate. So when the patient comes, you put the patient on mechanical ventilation. So what is our primary aim to do the ventilation, mechanical ventilation? So what are the things we are doing in the mechanical ventilator? We are doing oxygenation and ventilation. That's basically, that's doing 2 things. When the patient, why the patient need a ventilator? If someone is struggling to oxygenate in case of pneumonia, or someone is struggling to ventilate. That means they are not able to eliminate the carbon dioxide or not able to do the mechanical minute ventilation. So some people are both components struggling. So why we are prescribing ventilator basically for 3 reasons: to improve the oxygenation, or to improve the ventilation, or sometimes for both. That's the first thing. So first thing, that one. So the basic one, I think you already know about this mechanical ventilation 1. So what are the parameters controlling the oxygenation? Anyway. Actually, I come out of the slides, basically. I change the pattern. So what are the parameters dealing with the oxygenation? In any patient, even physiologically breathing patient or mechanical ventilator patient. First one is how much of oxygen he is taking. That's FiO2, fraction of inspiratory oxygen. Second one, there are the umbrella term that's called mean arterial pressure. If more and more mean arterial pressure, more and more oxygenation. So mean arterial pressure mainly governed by 3 things. One is P, other one is the tidal volume, other one is how many times the patient on inspiration. If the patient on more and more time on inspiration, more and more oxygen delivered. It's very simple. That's the thing you are talking about, the so-called inspiratory time. The inspiratory time, how it's improved oxygenation. You keep the patient artificially for more time on inspiration, then more oxygen is diffused. That's the thing. So basically the mean airway pressure determined by 3 things. How much of tidal volume you are giving. Why the airway pressure and the tidal volume, how it's related. How the airway pressure and the tidal volume is related. Even physiological breathing, it is related. Usually related. If more and more tidal volume, you need more pressure. So that's the thing. If you are prescribing 500 ml of tidal volume for a patient, same person, he need roughly around 30 centimeter water of pressure to deliver the tidal volume. If you prescribe 400, then definitely it could be less than 30. So mean arterial pressure or the peak pressure or plateau pressure, whatever it is, it's directly related to the volume of the tidal volume. It's directly to the volume. So that's why, whatever the ventilation you are giving, it's a neurological reason you intubate the patient for low GCS, or the patient for pneumonia you are intubating, or patient for COPD you are intubating. Whatever the reason, the current guidelines suggesting low tidal volume. Why? Because tidal volume is the major determinant of the mean airway pressure. If you are giving more tidal volume, more pressure you are giving, more energy you are giving, you are damaging the lung. So whenever you are trying to oxygenate the patient, so improve the oxygenation of the patient, even you wanted to improve the oxygenation, better to keep low tidal volume. So whatever we are studying in the next 3 cases, basically covering this. So tidal volume, it's directly related to the pressures reached. So whatever the pressure is. And the third one in the mean arterial pressure is P. So Madam is actually in the mechanical ventilation type 1 slides cover a lot of things about the P. So what is P? I think some of what is P? Anyone? PEEP is a positive end expiratory pressure to keep the alveoli to open throughout the respiratory cycle. So what is auto PEEP? She explained very well about the auto PEEP now. So auto PEEP, how it's generated, it's very simple. If now the ventilation, basically we are delivering the air by another machine. So you are push the air into the lung, that should have come out passively during the time you are getting the respiration. So if you gave around 400 ml of tidal volume into the lung, the next breathing you are about to give another 400. So whatever you are giving, at least 450, at least 350 has to come out before the next part. If that's not happening, the air stuck there, then that means keep the alveoli a little bit more open and creating more pressure. That is auto PEEP. So each and every time the air gets stuck there, then it will generate more auto PEEP. So these are the concepts we will discuss later. I go through the slide later, but we need to come to the, we need to get some idea about what we are doing. Now, come to the case. So, if you want to increase the oxygenation for any disease state like pneumonia or ARDS, what is the primary aim of ventilation? When you are putting in the patient for oxygenating for pneumonia or ARDS, our primary aim to oxygenate to save the patient. If we are failed to oxygenate, what will happen? The patient will die soon, develop multi-organ failure, and patient will die soon. So our primary aim is oxygenate the patient. While our aim is oxygenation, we should think about not to damage the already damaged lung. The second thing. So we are ventilating the patient. So you asked to prescribe for a patient with severe pneumonia and ARDS. So our aim is to improve the oxygenation. While improving the oxygenation, we are not able to damage the already injured lung. That's you should keep in your mind. Already injured lung. The ARDS lung is already injured lung. So not to injure the lung. The third one is, while you are balancing both, what will happen? You may not be able to adequately clear the CO2. That is called permissive hypercapnia. So we will set the target. Okay, I'll accept some amount of CO2 unless the patient is not touching it. pH is 7.2 is accepted. So the ARDS ventilation strategy is very simple. Aim for oxygenation, avoid further lung damage, accept some amount of CO2 reduction. So the prescription is low tidal volume based on the ideal body weight. Why ideal body weight? I just give a case scenario. We got an obese man, 100 kilogram gentleman, came to the ICU. His height is around 155. And another gentleman is same person, 100 kilogram. His height is 175. So do you ventilate the same tidal volume for both? No. These FCCS slides basically always telling about the volume, because in US they always put on the patient on volume control ventilation. So that's why these case scenarios are put on the volume control. But we are usually not prescribing volume control, but that doesn't matter because both are same at the end. Okay, so now you clearly know why we need to prescribe the ventilation for ideal body weight. Why? If you are prescribing for person for his actual body weight, if they become more and more obese and more body weight, if you prescribe, if someone you get 150 kilogram, then 6 ml per kg, 150, 900 ml you need to prescribe. So what will happen? Airway pressure was very high. You may need to go for 50 even, the lung get damaged. So it's very clear that ideal body weight is usually correlate with the lung volume. So ideal body weight usually correlate with the lung volume, person lung volume. So you have to calculate the ideal body weight and then keep on lowest possible tidal volume. What is the lowest possible starting tidal volume? 6 ml per kg. So how I am prescribing for an ARDS patient? First, I need to save the patient. So I put an FiO2 on 100. Tidal volume 6 ml per kg of ideal body weight. I didn't tell about how to calculate the ideal volume. You can refer, but I want to tell the principle. So second prescription 6 ml per kg tidal volume to keep lowest possible tolerable tidal volume. Then the third one. What are the parameters? Improved oxygenation, P, inspiratory time, tidal volume. These are the things correlate with the mean arterial pressure. So I set the P according to the oxygenation status. So how much? Usually we will start a higher P, start around 8 or 10. Then I adjust the PEEP and FiO2 according to ARTSNet guidelines. There's a guideline is there. You can see, you can download it in the mobile phone and see, okay, this much of PEEP, how much of FiO2 I need to set to get the target saturation. Third one, always keep more inspiratory time. Then more time the patient on more oxygen delivered because of patient more on the inspiratory phase. So what the problem will happen if the patient more on the inspiratory phase? Air may not be escaped. So CO2 can be leaked. So ARDS setting is very simple. Tidal volume 6 ml per kg for ideal body weight. Start around PEEP of 8. FiO2 start around high based on the ARTSNet guidelines. So start around 100 and then reduce. Third one, always try to keep inspiratory time higher, preferably IE ratio 1:, start around 1:1.5 and then go to 1:1. And check do the ABG and check how the things are going. Then adjust. That's about the ARDS setting. So what will happen when you prescribe like this? Oxygenation started to improve, but CO2 may stuck within that. But we never look after the CO2 in case of severe ARDS. Always we are looking the pH. That's the first thing. Second thing is ventilating asthma patient. Okay? Out of these ARDS, you always try to keep plateau pressure less than 10. What is plateau pressure? See, explain. I'm there here in CTRB. So plateau pressure is the pressure when the alveolar is in the distance and the alveolar maximum distance and time, what's the pressure is there, that is a plateau pressure. So plateau pressure usually is a contest in volume control ventilation. With the patient on pressure control ventilation, you don't need to worry about the plateau pressure. Plateau pressure and the peak pressure both are same most of the time. So what is the target plateau pressure in ARDS? 30. You try to keep plateau pressure less than 7. So what is the prescription of ARDS? 6 ml per kg for ideal body weight, PEEP of 8, FiO2 based on the ARTSNet guideline. If I am not sure about that, start on 100 or 1. And then IE ratio 1:1.5 initially, and if not oxygenate, go for 1:1. Then always try to keep plateau pressure or peak pressure less than 30. So, meantime, I need to adjust the alarm as I am correctly doing or not. And I will check the saturation and regularly do the ABG and change the setting accordingly. So ARDS done. Second one. Thank you guys. Okay. Second one about how to prescribe for an asthma. So then I will go with the slides. Podium because you all get sleep and just listen. Asthma admitted to ICU for acute asthma situation, intubated, sedated, and receiving mechanical ventilation. Weight is 59 kilogram and the height is 175. On admission, peak pressure is 47 and the plateau pressure is 25. So the difference between plateau and the peak is quite high. That means it's ARA resistant. If the difference between the plateau and the peak is low, that means poor compliance. Quite simple, but usually we don't use that because we are usually not prescribing volume control. So 6 hours later, the peak pressure goes up and the plateau pressure remains changed. What is the meaning of that? It's quite simple. The resistance is going up. Resistance is going up. So the initial mode of ventilation always assist control. Modern prescription always assist control. There is no prescription of SIM or anything. As I said, even asthma, the aim is to keep the patient oxygenated. So usually in US they will prescribe a higher oxygen and then come down. We usually start on a moderate one and go up. Then the rate is 15 per minute and tidal volume 400 and peak 5. So, for the asthma, the problem is what? It's very simple. Air will go inside the lung. Because large airways, there is no problem. Only the problem is in the small airways. So air reach into the lung. So we are actually delivering the air forcefully by the positive pressure. So a lot of air go inside the alveoli, and it has to be come by passively. You should understand that one. Even with the mechanical ventilation, air should come passively. So it comes through the constricted small airways because of the hypersensitivity of the airway, that is the asthma. So whatever it's go inside, what will happen here? It will not come out. So definitely the 3 things will happen. One thing, first thing is air will stuck there, air stacking. So air stacking create what? Autopy and dynamic hyperinflation. What is dynamic hyperinflation? Because of the air is going and not coming out, then the alveoli started to distend. So it's every breath it started to distend more and more. That is called dynamic hyperinflation. It's inflated more and more. Then, because of no air coming out, CO2 started increasing the blood. So because of the CO2 is increased more and more, one point CO2 narcosis will happen and the patient will collapse. So this is about the asthma physical. Even you are ventilating the patient. So if the patient is spontaneously breathing, things are quite better than put the patient on mechanical ventilation. Why? So because you're not able to get more air by your. Because you will get tired, but machine will not get tired. So that's why the people are suggesting as far as possible, better to avoid to put the patient on mechanical ventilation in severe asthma. If it is life-threatening asthma, no way. You can't wait for the things happen spontaneously. But you should know the limit. So if you are intubating an asthma patient, that's a nightmare. Because you are doing the things completely against the pathophysiology. You got the point? Here they put an acidosis and PaCO2 is 75. Oxygenation is okay here. And peak pressure 55, plateau 25, overall peak 12. IE ratio 1:1.5. Respiratory rate 15 breath per minute. Blood pressure 90/50 and the heart rate is 150. So definitely it's an acute severe asthma. Blood pressure is low because of what? It's a pure and simple asthma. There is no sepsis. Don't tell that sepsis is the reason for low blood pressure. What is the reason for low blood pressure here? Again, answer is multifactorial. My answer is multifactorial always. So you should explore the multifactor. First thing is because of increased intrathoracic pressure, because of air stacking and high O2P, there is no venous return, there is no blood into the heart and they're not able to generate any cardiac output adequately and low blood pressure. That's the first thing. Second thing is, again the same. Sometimes you are ventilating without concerning about the airway pressure. There may be a pneumothorax already developed. Could be a catastrophe very soon. Tension pneumothorax about to happen. Third thing is, patient already on hypovolemic. Why hypovolemic? Using all the energy for the breathing up to now. So the patient is actually hypovolemic. Usually the asthma patients are hypovolemic. So this is the answer basically. All five can be. And then again, myocardial ischemia. How the ischemia happen? The demand is very high, and later on you may not get adequate oxygen also, but this patient is adequately oxygen. So, what do you think about that setting? Are you happy with the setting? About asthma. I will come back to the asthma setting. So what's the problem now? What is the rate? 14 breaths per minute. So what is the one respiratory cycle for? 4 seconds. Okay? So inspiratory time roughly little bit of difficulty. They put on 1.5, so you're not able to calculate by own. If someone is good in maths, then quickly they can tell. So we make it okay. If 1:1, that's roughly 2 seconds. Now it's less than, yeah. But expiratory time is not ideal. What is the usual expiratory time? 1:2? What is the usual IE ratio? Or 1:2. Usual IE ratio is 1:2. So if you are keeping on a patient with asthma, so what is the IE ratio you expect? What you need to do basically? Increase the expiratory time. That's your first aim. Increase the expiratory time. Physiologically, what is asthma respiratory auscultation finding? Then you can easily tell the answer. What is auscultation finding on the asthma? Medical students. Bilateral polyphonic wheeze with increased expiration. So physiologically the body keep more time for the expiration. So if you are not giving that, then what will happen? So the setting changes. Here the rate is already reduced. So I will adjust the IE ratio to 1:2 and reduce the, I will try to reduce the tidal volume. When you reduce the tidal volume, what will happen? Inspiratory time will reduce, clearly mentioned. Expiratory time will improve. And IE ratio, so more gas can go out of the lung and it will help. What about the auto PEEP? How you can improve the auto PEEP? You need to reduce the tidal volume. If you are giving more air in for the breaths, it will stop. So you need to reduce the tidal volume as much as possible within your possible chance, and then if everything fails, you need to disconnect for some time and then connect. So asthma ventilation, again started on low tidal volume. Always, if you are giving low tidal volume, then you are not generating more airway pressure. So airway pressure is within your control. Second thing is, it will give less inspiratory time, more time for expiration. Third one is, your peak pressures and the plateau pressures within your control. Second one is, the second prescription is, you can keep the FiO2 according to the oxygenation need. PEEP, always low PEEP. Sometimes we will prescribe even zero PEEP initially. So asthma prescription, always try to prescribe less than ideal PEEP. Usually we will start around 3. And if auto PEEP is detected by expiratory hold maneuver, then we will reduce the PEEP to 0 even. The third setting is IE ratio, usually more than 1:2. We start around 1:2.5. And respiratory rate, what is the respiratory rate? That's an important physiological understanding you should have. When you are increasing the respiratory rate, what will happen? Time for the expiration, it's reduced. So always you need to think about that. If you are ventilating a patient, if you are increasing the rate, you are reducing the time for expiration. So we will keep moderate rate, 40 to 60 is acceptable. So this case is clearly said about that. So this one I already discussed. So what is the immediate change you do? Given answers, reduce the respiratory rate. If I put the fifth one, reduce the tidal volume, that also has to be considered. What about the COPD? What's the difference between the COPD and the asthma? Do you think you will get a severe hyperinflation like asthma and COPD? Usually no. COPD, the difference is here the irreversible component of for the resistance. It will be there. One small tidal volume, 6 to 8 ml per kg. Adjust the expiratory time. Again, you need to think about the auto PEEP. Here, you no need to bother about the pH. You can keep a low normal pH. And again, reduce that's important. Asthma or COPD, you should reduce the resistance by giving bronchodilators or magnesium or steroids. How we wean the patient from the rest? So, what is weaning? Anyone? So weaning from mechanical ventilation, basically whenever I'm doing the lectures about weaning, I usually tell it's just recall how we wean from exclusive breastfeeding. So that's the thing. Initially, we'll start some supplementary feed and then increase the supplementary feed more and reduces the exclusive breastfeed. And then later on, we'll stop the exclusive breastfeed. That's how the thing is coming. So when we decide for weaning the kid usually if we think the kid can tolerate on his own feet, we can wean. So when the weaning starts, about mechanical ventilation, when the weaning starts, anyone? This is a very important question. Most of the time I have asked the question in several forums. Weaning start at the time of intubation. Weaning start at the time of intubation, because if you don't know when to take out of the tube and ventilation support, at the time of intubation you will keep more. So, I will give an example. A person found low conscious level at the road because of the drug overdose. That gentleman, you put the tube for airway protection. So when you will extubate the patient, his lung is perfectly okay, he is a swimmer and found unconscious in the roadside. So when you will take out of the tube? At the time when he is fully awake, I will take out of the tube. And another person come with severe pneumonia, ARDS, we will put the tube for oxygenation. So when we take out of the tube, or when we come out of the ventilator support, if his demand met by his own, we will take out of the tube. So weaning also, it's very simple. When we are supporting the respiratory, because this is actually a complex topic. Mechanical ventilation too is a complex topic. So going there is actually alienate me from the discussion. That's why I can't hear again and again. Sorry for that. So weaning is basically you are balancing the support and the demand. When the support is not needed and the demand is coming down, then you can take out of the tube. So weaning protocols mainly designed based on this. And the second one, I think first one, cause of respiratory failure has improved significantly or resolved. Second one, if he is able to clear the secretion. I usually tell you can take out of the tube if the patient is able to open the mouth when you ask. That's the most of the time I usually told that one. Then second one is patient able to adequately oxygenate. If the patient's saturation is more than 90 with the minimum oxygen support, then you can think about weaning. Patient on minimum PEEP support. Other one is initiate inspiratory fund. The last one is really important. Is not on much of hemodynamically support. If the patient on noradrenaline 0.6, vasopressin 4, but his oxygenation and everything is fine, you will take out of the tube, but will happen. Because of his cardiac work, his demand is definitely high. Even though he is breathing and oxygenation is fine, the demand is high, and then in 4 hours time, he will need more oxygen and he will again go for tube. So these are the 3 parameters. These are the 3 parameters you should check before take out of the tube. So weaning is slow down or reduces the support you are giving for oxygenation and ventilation. That is weaning. Then extubation is, if you are thinking your support is enough, you don't need to support anymore because he is on his own, he is able to maintain the oxygenation and ventilation, you will take out of the tube. That is extubation. So don't confuse both. Weaning is reducing the support. I clearly told, when the patient on exclusive breast milk, you start on supplementary feed first. You reducing the increasing the supplementary food and reducing the exclusive breast milk. Then one point we will stop that now. So the same thing. Weaning is reducing the support. Extubation is take out of the support. So before going for an extubation, you should check the readiness of extubation. There are hundreds of tools, but they are all the tools validated several times, but they are not superior than your clinical decision. So actually the extubation decision It's always based on the clinical experience most of the time. And 1 out of 5 patients will end up in reintubation. So you no need to fear about that to take out of the tube. Definitely, the statistics always, everyone, surgeons or physicians, everyone knows statistics. You never forget, fight against statistics. It's there, statistics is always there. So out of 5, 1 patient, you may need to reintubate. That doesn't mean you scared to win. That doesn't mean you need to scared to win. So, but you always follow the protocol to see the readiness. The first one is what? Spontaneous breathing trial. To understand that, I usually tell that's a test drive. In a controlled situation, you let the patient to breathe on his own and see how he is doing. That is a spontaneous breathing trial. So what we usually do in spontaneous breathing trial, what is we are doing in spontaneous breathing trial? We will put the patient on spontaneous mode with minimum pressure support, usually 5 or 8, PEEP of 5 or 8, usually we keep on 5. I usually make the things easy, ask the people to keep on same number, PEEP 5, pressure support 5, and keep the patient in the ventilation for 20 to 20 minutes and see the response. What are the things we need to monitor? Work of breathing, respiratory rate, how the saturation is going, and do the blood gas and see how the things go. If he's passed the testing, that's mean what? He's ready to come out with something. So spontaneous breathing trial is a valid tool. It's called test drive. It can be used before extubation. So weaning is basically when the patient is ready to breathe on his own, when the support and the demand is met by on his own, you can check out of that. That is actually, you can extubate the patient. So we see that one as a trial in spontaneous breathing. We put on spontaneous breathing with the PEEP of 5 and the pressure support of 5 for 20 to 20 minutes. But some people will keep that spontaneous breathing trial up to 2 hours. That practice has some issues, but usually we will go for 20 minutes. If failed, then we will put back into the full support. And do that one tomorrow, day after tomorrow, while correcting the things. Negative inspiratory force means what? Any idea? What do you think it's actually, we are measuring how much of negative pressure patient created by on his own while patient on positive pressure ventilation. Guys, you finish the mechanical ventilation one, you know what we are doing is a positive pressure ventilation. But the patient physiologically breathing in negative pressure ventilation. So we see how much of negative pressure he can generate. That is negative inspiratory force. The last one, rapid shallow breathing index. It's mentioned in something wrong. Rapid shallow breathing index. Actually, we see how much of work of breathing basically is doing. What is rapid shallow breathing? The classic example is when you see the dog after running, that breathing is a rapid shallow breathing. I didn't want to tell any patient history. If no one sees the dog, then I can't tell this example. That's a rapid shallow breathing. If you are breathing like that, that means you are getting smaller tidal volume in a large rate. So you're not able to make your demand. So rapid shallow breathing is basically like that. You need to create large volume with smaller rate. That means you are breathing normally. How we breathing? We take 5 seconds for each breath, roughly. Normal breathing, we take 5 seconds for breath. For a minute, we are breathing only 10 to 12 times. That means you are taking very slowly in and out. If you are breathing like rapid shallow, that means there is something wrong. Your capacity is not enough to take out of the tube. So So that index should be less than 126, 110 or 126. 110 is the number. It's not it's an arbitrary number, but you should know the contest. So contest is you should be able to breathe as like normal, larger tidal volume, smaller rate breathing. The number is basically telling faster, smaller tidal volume. If more number means faster, smaller tidal volume. Less number means large, small rate or less rate. This is about the rapid cell of breathing index. So summary. So ventilator parameters are actually integrated. You have studied in the first lectures. So oxygenation depends on FiO2, mean airway pressure, those two. Mean airway pressure on three things in the mean airway pressure: tidal volume, inspiratory time, and the P. Okay? ARDS ventilation, low tidal volume, high P. FiO2 adjust according to ArtsNet guidelines. Inspiratory time. More inspiratory time is preferable. You start around 1:1.5 and you can increase 1:1. See, monitor the patient clinically and arterial blood gas. You can allow the patient CO2. Always you will look at the pH, not the CO2, and if the pH is less than 7.2, it's acceptable. That is called permissive hypercapnia. This is about ARDS. So tidal volume, usually 6 ml per kg on ideal body weight, because actual body weight is not represented the lung volume. Second one, asthma ventilation. Asthma physiology is air can go in and not come out of the lung. So is invariably air stuck into the alveoli that lead to dynamic hyperinflation and autopy. So we need to prevent that by ventilating the patient. Again, low tidal volume, FiO2 based on the saturation target. And then P, use minimal P. Even you can go for 0. And expiratory time, you need to keep more expiratory time. So preferably not more than the physiological one. 1:2, 2.5, even 1:3 you can go. If you're not able to control the air stuck inside, you can disconnect liver. And treat the underlying bronchospasm by bronchodilators, magnesium sulfate, and steroids and ketamine like new agents. Then COPD is almost similar as asthma, but you don't need to worry much about the CO2 because already the body adapted to more CO2. These are the 3 case scenarios. Then the fourth one is weaning. Weaning principle basically based on the patient no need more support. The patient is now able to breathe on his own. The demand for respiration is when the demand is come down and his capacity is improved. The balance is shifted more towards the patient side, and you can take out the tube. To see is it happen, to see that one, you can do the spontaneous breathing trial. Basically, that is you let the patient to breathe on his own with minimum support and see how he's doing. If he's passed the test, you can take out the tube. This is the whole summary of the ventilation tube, and with the case scenarios, you can ask them whatever the burning question you have. Thank you, guys.